Welcome to the Enhancing Clinical Practice and Outcomes stream of SNOMED Expo 2024. My name is Jim Case, and I'm the Chief Terminologist at SNOMED International. I'll be moderating today's session. All questions will be answered at the conclusion of the presentation. Online attendees, please use the Q&A button to type your questions to the presenter. On-site attendees, please use the microphone that will be provided in the room. I'm now pleased to introduce Hwang from the University of Nebraska Medical Center, who will be presenting towards Semantic and Syntactic Interoperability of Cancer Synoptic Reports. June, please go ahead.
Good afternoon, everyone. My name is Hwang, and I'm a postdoc researcher at the University of Nebraska Medical Center, specializing in standard terminology, particularly SNOMED CT. I want to extend a warm thank you to SNOMED International for the opportunity to present at this year's SNOMED Expo because it's being held in Korea. As a Korean, it's a special honor for me to presenting here, and I'm excited to share our recent work on improving the interoperability of cancer synoptic reports. Actually, my first language is Korean, and here are so many Koreans, so I've been thinking about doing presentation in Korean instead of English, but I decided to stick with English for the presentation, and we'll answer question in Korea later. So if you have question at the end of the presentation, please feel free for me. So yeah, before diving into the details of our study, I want to quickly go over some key points about pathology reports. As you probably know, these pathology reports are essential for medical diagnosis and treatment planning. They offer critical insights that guide clinical decisions. Over the past few decades, we've seen major efforts to shift pathology reports from free text to structured format like synoptic reports. Institutions like the College of American Pathologists and the International Collaboration on Cancer Reporting have developed their own protocol to standardize data collection. This improves the clarity, consistency, and the usability of reports, making life easier for both healthcare provider and patients. However, despite these advancements, challenges around interoperability still remains. As patients increasingly move between different clinical settings and new data collecting devices emerge, interoperable data become more crucial. It's essential for effective data sharing, not only advanced researchers, but also to improve patient care, especially with the growing importance of patient-generated health data. So our study seeks to address this challenge by focusing on enhancing interoperability in pathology reports. Our approach has two main focuses. First, terminology binding. This is critical for semantic interoperability, ensuring that the terms used in reports are understood consistently across different settings. Second, data format compatibility. We also work on building a digitalized form with the syntactic interoperability to ensure that data structures are compatible, allowing for seamless data exchange. In today's presentation, I will explain how we bound the terminology binding and created a structured form for the target dataset. I will also walk through the method we used and supported by some real example and share the result we achieved. And let's dive into the details. These slides provide an overview of the process we followed in our study. Sorry, there is some issue with the presentation file. Yeah. First, we selected the target pathology report, which become the foundation for our work. We also choose the terminology system and the tool for semantic and syntactic interoperability. Next, we tackle the terminology binding process, focusing on semantic interoperability. And if needed, we made some adjustment from a data set to ensure everything was aligned. Then we move on to building a structure form to support syntactic interoperability, which enable effective data exchange. Finally, we conducted a review with the user, including pathologists and other key stakeholders. Based on their feedback, we made some changes to the binding and building praise where necessary. So let me now break down each of these steps in more detail. We began by selecting the colorectal cancer dataset from the International Collaboration on Cancer Reporting, commonly known as ICCR, as our target dataset. The ICCR offers globally recognized free guidelines for cancer pathology report, and we specifically choose colorectal cancer because of its global prevalence and public health impact. Our focus was on pathology finding, including both gross and microscopic examination, while excluding clinical findings. We also aim to cover all essential data elements and a few optional ones. Next, we focus on selecting tools to enhance both semantic and syntactic interoperability. For semantic interoperability, we use SNOMED CT, which include a wide range of concepts tailored for cancer pathology reporting developed by the Cancer Synoptic Reporting Working Group under the SNOMED CT International. For syntactic interoperability, we use the FAST healthcare interoperability resource known as the FHIR framework, which is internationally recognized for ensuring data exchange. For the synoptic reporting format, particularly for entity and value pair, we utilize the FHIR questionnaire. We simplify this process using the form builder from the National Library of Medicine. Before performing terminology binding, we explored approach. For instance, let's assume we are looking for the SNOMED CT concept related to lymphatic and venous invasion, particularly focusing on small vessel invasion. While we easily found this concept, the lymphatic invasion by tumor present with the finding semantic tag, but we noticed some issue that this is the primitive concept as it has just yellow circle. It limited its usefulness in running the query based on its definition. To resolve this, it was necessary to revise editorial guidelines. However, even with change the guideline, there is another issue. It could require significant resource to manage them. Let's consider the scenario where we created concept for every combination of histology type and the sites. Using the ICCR colorectal cancer protocol as an example, with 10 histology types and 9 locations, and we would need 19 concepts just for colorectal cancer alone. So that's quite a lot. Given these challenges, we decided to bind concepts separately for entity and values. For example, we use the observable hierarchy for question and a different hierarchy for the answer, such as body structure or morphological abnormality. These allow for more flexibility and precision in our binding process. Uh, Take for example, the status of small vessel invasion. For the question, we use the SNOMED CT concept, presence of direct invasion of primary malignant neoplasm of cecum and or colon and or rectum to lymphatic vessel and or small blood vessel. And for the answer, we went with a simple present. Uh, Now it's important to remember that the data set we are working with was designed for people, not computer, which can complicate terminology binding. A good example is lymphatic and venous invasion. It's tricky because term like not identified can mean that neither small nor large vessel invasion was identified. And while people can interrupt this correctly in context, but computers have struggled. That's why, when necessary, we reconstruct these data elements to make sure each one has clear and one meaning so that they can be properly bound. Now I've explained how we handle the binding process with SNOMED CT. Let's move on binding the FHIR questionnaire using the NLM form builder. Since we've adopted the observable entity approach, where we separate question and answer, we needed a tool that supports that structure. The NLM form builder is perfect because it allows us to apply standard terminology to both question and answer. Plus, it offers useful feature like a conditional display. Let me work with through an example. When binding a questionnaire for tumor deposit, we start by entering the question text and its corresponding terminology, standard terminology. For instance, I'd put 12A6759003 in the code field and its pre-specified name in the display name. For the system field, I'd put in the SNOMED URL to identify the standard system. Next, we selected the data type. Choice work well here, and just like we did for the question, we enter the code, display name, term, and system URL for answer option. We can also customize things like a layout, requirements, and or any other settings to fit the data set need, which help tailor the questionnaire to our specific structure. The ICCR require pathologists to report the number of deposits when they are present. To address this, we created a question that covers all necessary details, but instead of using the answer list, we provide a numeric field. This way, pathologists can directly enter the number based on their observation. We also include the conditional display feature, so the numeric field only appear when tumor deposits are actually present. This feature is really useful for applying conditional logic and ensuring we capture detailed information only when it's needed. Since it's not more practical to list every possible answer, like all the different histologic types, Both synoptic reports provide a list of most common response. But if a pathologist doesn't see the exact option they need, they can still add any information. This approach keeps the questionnaire flexible while maintaining a clear structure. Finally, we share the JSON part in FHIR-R4 format with a group of pathologists and stakeholders for their review. We had regular online meetings to go over the feedback, discuss the binding result, and address any concern. This collaborative approach allowed us to make necessary adjustments based on experts' input, ensuring that our model was aligned with real-world clinical use. Now let's take a look at the result of our research. After reconstructing data, we targeted a total 162 elements for our study. Out of those, 128 was successfully bound to SNOMED CT. For the question, all bound concept carried the observable entity semantic tag, while the answer were linked to tags such as body structure, morphological abnormality, procedure, and qualifier value. We reviewed the data elements that weren't bound, and out of the 34 data elements, 27 were related to pathological category. The ICCR relies on the Union for International Cancer Control, known as the UICC system, but we couldn't find a suitable concept for those in SNOMED CT. However, since SNOMED International and UICC entered into a collaboration agreement last May, they are now working together to publish SNOMED CT concept for UICC categories. We are confident that this issue will be resolved soon. Now, let me show you the FHIR form we created. We can see the all elements we targeted with the question structure in the tree format for easy navigation. On this screen, we can enter the data and view the JSON version as well. This is where we input everything while binding the form using FHIR resource. And we are almost at the end, so let's dive into the discussion. By following the step I've just gone over, we've positioned ourselves to achieve both semantic and syntactic interoperability. We've leveraged existing resources like dataset from the ICCR, terminology from the SNOMED CT, and the form builder provided by LNM. While our study results aren't publicly available yet, but we do have plans to make everything accessible through the ICCR platform soon. We've made solid progress, but there are still some challenges we need to tackle. Although we've developed a digital form using the FHIR standard and completed terminology binding, we haven't implemented yet. To fully realize the benefits of our work, we recommend moving forward with implementation. Also, achieving semantic interoperability requires pairing each question and the corresponding answer to fully capture the meaning of the content. This approach, while more precise, does add some complexity compared to using single concept as within a concept with the finding semantic tag. Looking ahead, we plan to extend this method to remaining ICCR dataset, building on what we've accomplished so far, and to ensure consistency across our finding. We will also make sure the results are publicly available so we can share our work with the wide community. Our next focus will be on exploring interoperability in practice. We want to validate how well our approach works for cancer synoptic efforts. One strategy we are considering is setting up virtual system to send and receive the test data, which would give us valuable insight into achieving both semantic and syntactic interoperability. With these efforts, we aim to contribute the standardization and clarity of cancer synoptic efforts, ultimately improving communication and understanding among healthcare professionals. Thank you for your attention. I appreciate your time and interest in our work. If you have any questions or thoughts, I love to hear them.
Thank you. Ji-Yoon will now take questions. As a reminder, if you are in the room, please use the microphone provided to ask your questions. So I have one question. What do you think are the most important questions or the most important things that you learned during this process?
Something is understanding of the target data set, because I'm a terminologist, but I run the pathology knowledge, but these are very readers. So to perform the terminology binding exactly, we need to understand the pathology report meaning and collaborate with the pathologist. But I think it is not only for the pathologist, but also all the terminology binding area.
I'm Nat from Thailand. This is not really related to the SNOMED CT that much, but I wonder why you use the questionnaire resource from FHIR. Is that really a specific reason to use the questionnaire?
Actually, the FHIR version 2 is the FHIR version 2 and the HR7 version 2 and the FHIR is the commonly used in the medical field for the syntactic interoperability. But as I know that the HR7 version 2 is the has a flexibility to apply implementation in the system. So that's why the FHIR is immersed, and so that's why we just use the FHIR questionnaires.
Okay, thank you.
I'm Kim from Korea, radiologist. I have a similar experience about the pathology report convert to the form composed by the form builder with the questionnaire lists. But the my problem is if we use the questionnaire, after that, the result cannot query by the standard methods such as diagnostic reports resource or the observation resources. So what is your solution about that problem? I have, I have that problem is that the frustrating problem after the project.
네. I will present in Korea. 사실 제가 그 파이어나 이쪽의 전문가는 아닙니다. 그치만 그냥 이제 저는 이제 데이터를 관리하는 측면에서 그리고 시멘틱 인터퍼러빌리티를 위해서는 이제 파이어가 이제 쓰인다는 건 이제 기본으로 했고요. 저희가 아까 보셨다시피 그걸 밸리데이션을 다 돌렸습니다. 그래서 일단은 이슈가 없는 거, 구문론적으로 이슈가 없는 거는 이제 확인이 됐고요. 사실 그 다음에 이걸 임플리멘테이션 그 헬스 인포메이션 시스템에 이제 적용을 하는 거는 실제 이제 개발자분들의 이제 코어가 사실 필요하다고 생각합니다. 저희가 가지고 있는 걸 당장으로 이걸로 이제 뭔가 데이터를 저장하는 거는 제가 아닌 걸로 알고 있거든요. 그래서 그거를 어떻게 그 히스에다가 이제 붙여 넣을지 그런 거는 사실 저 말고 파이어 쪽의 선생님들이 조금 더 필요할 것 같고요. 그리고 단순히 저것만 돼서는 안 될 것 같고요. 결국 스노메드 말씀하셨던 것처럼 스노메드 그 쿼리가 만약에 안 된다고 한다면 스노메드 CT를 뭔가 다 구축이 된 다음에 그 쿼리가 움직여지는 거지. 단순히 저 코드만 있으면 저 코드는 아무 의미를 가지고 있지 않거든요. 저 코드가 가지고 있는 데피니션을 파악할 수 있도록 시스템이 그거 뒷받침되어야 된다고 생각이 됩니다.
Okay, one more simple question is that, I'm sorry. If you, 예,
답을 먼저 드릴게요.
So, in fact, I'm not an FHR, the fire expert. So I'm only just dealing with data management and regarding the fire. And then as I have displayed for you that we have actually run this program for a long time. So we are quite sure about this program can handle the semantic issues, can ensure the semantic interoperability. And then, but in regards to the implementation of the further system, we actually require some input from the actual engineers and the IT experts. So in that sense, so for the future, for the further implementation, as I told you, we have to invite real experts from the engineer part and the IT part, and also as you pointed out, there's a SNOMED CT query issue that SNOMED CT has been fully implemented. After that, so we have to define the coding. So that should be a right procedure, I believe.
okay. One more simple question is that if you cannot find the appropriate tone, what is the solution? Waiting? Or
Actually, as I mentioned, most of the concept for the cancer synoptic reporting is already authored by the cancer synoptic reporting working group. So, and in addition, if I were in that case, actually the mentor in the University of Nebraska Medical Center, the Professor Scott Campbell, is collaborating with the SNOMED International. So actually, it is part of that project. So if we need some new concept, he authored and reviewed by the SNOMED International terminologists and published in SNOMED International version.
Thank you, Gio.